My name is BK. Today, my case study is about motor vehicle accident that causes multiple injuries, including central cord syndrome. This is a 34-year-old male, unhelmeted driver of motorcycle crash and T-boned left side by a vehicle. The vehicle was traveling at unknown speed. He was ejected from motorcycle and reports loss of sensation to all four extremities. There was no breath sounds on right lung in the field, and it was decompressed by a 14-gauge needle. Transverse contusion across chest reported by EMS. Glasgow Coma Scale was 15 in field. On arrival to Trauma Bay, patient was able to move toes and shoulders and complained of pain in neck and discomfort in back of head. Also, patient reported pain in right hip and left ribs. Patient states he was not drinking or using illicit drugs today while driving. Patient has past medical history of hypertension and past surgical history of left rotator cuff surgery. Patient currently smokes tobacco products and drink alcohol beverage and use marijuana socially. Patient has family history of cancer and he is allergic to cephalexin. Review of system shows that multiple abrasion had laceration, facial pain, positive for weakness and numbness in both arms and legs, positive for chest pain from contusion, dry mouth, positive for nausea, positive for the right hip pain and weakness in four extremities, and using illicit drug. At field, blood pressure was 155 over 106, heart rate 91, respiratory rate 22. After fentanyl injection, blood pressure was 106 over 84. When patient arrived at Trauma Bay, blood pressure was 104 over 65, heart rate 78, respiratory rate 18, O2 sat 90-80%, and temperature 98.7. Glasgow Coma Scale was 15, which indicates fast response. Physical examination reveals that no sensation to pain in the right hand and bilateral feet, 1 out of 5 grip strength in right hand, 3 out of 5 grip strength in left hand, 4 out of 5 bilateral ankle extension strength, and there was bruise over right eye and large 5 and 7 centimeters laceration over right eye and forehead. Cervical collar was in place at neck. Diminished breath sound was present bilaterally. There was bruise across anterior chest, 3 centimeters of laceration and abrasion over right hip, and bruise at right anterior thigh. From lab results, ALT, AST, and WBC were significantly abnormal. X-ray at pelvis shows mildly displaced comminuted fracture of right iliac crest. MRA for cervical thoracic lumbar spine shows concern for cord edema at level of C4. CT head without contrast indicates soft tissue swelling noted in the right face, consistent with a hematoma and soft tissue defect, and CT chest abdomen pelvis with contrast reveals fractures of the right fifth and sixth ribs and mild underlying pulmonary contusion, and comminuted mildly displaced right iliac crest fracture with surrounding soft tissue edema and fat stranding. So from subjective and objective data, diagnosis can be right facial forehead eyelid laceration, mildly displaced comminuted fracture of right iliac crest, fractures of right fifth and sixth ribs with mild underlying pulmonary contusion, and central cord syndrome by edema of spinal cord of C4. Treatment plans are plastic surgery consult for repair of facial laceration, eye lacerations, orthopedic surgery consult for ORIF or right iliac wig, neurosurgery consult for C3 to C6 laminectomy and posterior cervical fusion when MEP is over 85 to improve spinal cord perfusion as recommended in the neurosurgery guidelines on acute traumatic central cord syndrome. Admission to trauma surgery and ICU for surgical intervention and observation. And lastly, physical medicine and rehabilitation consult for acute inpatient rehab for functional decline in mobility and activities of daily living. At discharge from 30 days of rehab course, PT outcome was swing throat gait with supervision. OT outcome was retaining activities of daily livings with minimal assistance. And rehab nursing outcome was obtaining ability of self-caffeine toilet. So from this case, I could learn about central cord syndrome caused by trauma. Central cord syndrome is the most common incomplete spinal cord injury and very frequently caused by neck hypertension due to trauma such as motor vehicle accident. It is marked by a greater impairment of motor function in the upper extremities than in the lower ones, as well as by bladder dysfunction, and the variable amount of sensory loss below the level of injury. Sexual dysfunction is similar to all other spinal cord injuries, but central cord syndrome predominantly affects males. So in this case, patient requires intermittent catheterization due to urinary retention and Viagra due to erectile dysfunction at discharge. Here is my references for guidelines and management. This concludes my case study presentation about trauma with motor vehicle accident. Thanks for listening.